thank you so much for being here today. We are so excited to be able to bring these two amazing speakers to you today, and really appreciate that you're all joining us. Before we start, I just want to give you a little information about how this session came to be. These clinical research and clinical trials roundtables are a product of the Iowa Cancer Consortium's Research and Clinical Trials Work Group. And the purpose of that group is to identify and connect cancer research stakeholders and advocates in Iowa, and to find ways that we can all work together to educate the public, to make research and clinical trials stronger through collaboration in our state. So we're so pleased that you are here to be part of that. If you're not an Iowa Cancer Consortium member, we sure encourage you to learn more about that and potentially think about joining the Research and Clinical Trials Work Group as well. You can find membership information at www.canceroiowa.org. There are options for joining for free. And if you have any questions, you can find our staff contact information there as well. The consortium is a statewide coalition of individuals who are passionate about cancer control, working in cancer control, advocating for cancer issues. We have nearly 600 members. It's an excellent place to network, to make connections, to find resources for doing your work bigger and better. And we would love to connect with you. I'll put my email address in the chat here in a bit as well, if you'd like to connect that way as well. I want to introduce a couple folks before we get to our speakers. They are the co-chairs of the Iowa Cancer Consortium's Research and Clinical Trials Roundtable. Dr. Sneha Fadke is a breast oncologist at the University of Iowa Holden Comprehensive Cancer Center. And Shannon Benson is the executive director of the Iowa Oncology Research Association. They chair our work group, and we're very happy to have them with us today to help navigate through this event. Shannon and Sneha, thanks for being here.
Thanks, Kelly. I'm going to go ahead and introduce one of our speakers today. Thank you, everyone, for being here. Dr. Carmen Guerra is a general internist, cancer equity researcher, and professor at the Perelman School of Medicine at the University of Pennsylvania. She serves as the Vice Chair of Diversity and Inclusion for the Department of Medicine and the Associate Director of Diversity and Outreach for the Abramson Cancer Center. Her research has focused on developing and evaluating interventions to increase the participation of underserved populations in cancer screenings and cancer clinical trials. Dr. Guerra co-chaired two ASCO ACCC work groups that developed Just Ask, an unconscious bias training for cancer research teams, a site self-assessment to identify best practices in equity, diversity, and inclusion, and their joint research statement, Increasing Racial and Ethnic Diversity in Cancer Clinical Trials. She's a member of the American Cancer Society National Board of Directors and their Clinical Guidelines Development Group. She's one of the authors of the widely influential ACS colorectal, cervical, and HPV clinical practice guidelines. Welcome, Dr. Guerra.
Thank you so much for, I'm sorry, thank you, Sneha.
I have the privilege of introducing Dr. Schpero. So Dr. William Schpero is a health economist and assistant professor in the Division of Health Policy and Economics of the Department of Population Health Sciences at the Joan and Sanford I. Weill Medical College of Cornell University. He is also co-associate director for research at the Cornell Center for Health Equity. Dr. Schpero studies Medicaid and the healthcare safety net in the United States. Through his research, he aims to identify policy levers to address racial, ethnic, and socioeconomic disparities in health and healthcare. In past work, he has studied the drivers of waste of the United States healthcare system and analyzed the effect of key provisions of the Affordable Care Act. Dr. Guerra, I believe the floor is yours.
Wonderful. Thank you, Shannon and Sneha, for that warm welcome. And thank you, Kelly. Thank you all for the invitation to be with you today and for you to share your valuable time with us today to learn about this important and widespread problem of the equitable representation of patients on cancer clinical trials. Really a passion of mine, and you might see that come through today in today's talk. So before I start speaking, I just wanted to demonstrate a little bit slide here of my disclosures, both paid and unpaid volunteer work that you can see here, and then move on to the outline of what I'd like to speak about today before handing the floor to Will. So first, I was just going to briefly review the problem of underrepresentation of Black patients on cancer clinical trials and spend the majority of time with you sharing our experiences at the Abramson Cancer Center of the University of Pennsylvania with the problem and addressing the barriers that prevent Black patients from enrolling in cancer clinical trials. The first part of my work was focused on access barriers, but subsequently to the clinic. And then subsequently to that, I've been working more on access to trial barriers, and then where we might go with this problem in the future to continue to address the existing persistent barriers. So this is a crowd that includes a work group that's focused on the problem of clinical trials and underrepresentation. So you probably know all of this. Everyone understands that clinical trials are important for developing new cancer treatments. However, that there is suboptimal participation by all populations. Less than 5% of individuals with cancer actually participate in trials. And that underrepresentation is actually more severe for racial and ethnic minorities, as you can see from the table on the right here, which summarizes since 2017 to 2020, the proportion of individuals that are Black that have participated in oncology trials that led to FDA approvals of new therapies. You can see that we're inching along in the single digits for the proportion of Black patients represented in these trials. And to give you a comparator, Black African-American populations represent about 14% of the US population. And so we're really underrepresenting them. And this results in obviously less opportunities for them to participate in these trials to access new cancer treatments, but also it threatens the efficiency of the research because we're basically enrolling from just one part of the population and not including all individuals in all populations. And then finally, it just results in difficulties with the generalizability of the results of that research, since they may not apply to all diverse populations equally. And so many of you, of course, know there's a journey in placing a patient on a trial, which starts with obviously a cancer diagnosis, but then there are barriers that prevent that individual from accessing the clinic site to begin with. And then as you follow along the green here, there could potentially not be access barriers, and the patient does access the clinics, but then there is the barrier of perhaps there not being a trial available. And so patients exit in the red. And if there's a trial available, there's still a barrier that whether the patient is eligible because of the eligibility criteria, some patients exit here. And then ultimately, if there is a trial that they're eligible for, patients have to have that trial discussed with them and offered. And then the patient makes a decision whether to enroll or not. And so we've known that this is the pathway that patients follow, but only till recently, we didn't know what the individual contributions of all of these red boxes are until Joe Unger published a set of trials, a set of studies that indicated how significant each of those red boxes are. And what he found after reviewing and doing a meta-analysis and systematic review of all the available trials that showed the proportion of individuals along those that spectrum, that journey, he concluded that actually there was a half of the population that he studied had no trial available for their disease and their stage of disease. An additional 21% met the ineligibility criteria, and he concluded that actually 77% of the cases, there are structural barriers that you saw earlier, and that signify that there is no trial available for that patient. And then subsequently, among those who are eligible, he found that about 15% don't enroll and 8% enroll. Now, what he didn't know from that study was whether the patients were offered a trial or not. He just knew whether they enrolled or not. And so he concluded that about approximately 85% of the patients are prevented from enrolling by these structural and clinical barriers that are outside of their control. It's not them deciding whether they can participate or choose not to participate. And so he did a second study where he looked at studies where they did capture whether the trial was offered to the patient. And that's the study on the right. And he reviewed about 30 studies that met the criteria of having that data, and concluded that about half the people that have a trial offered actually go on to accept the trial, and only 45% decline. So this study got a lot of press. It was called When Offered to Participate. And I loved one other thing that he did in that study, which he actually went on to look at participation rates by race and ethnicity. And I've drawn out that data for you in this slide. And as you can see, participation rates between Black and white are pretty similar. And when he ran statistical tests, he could not find a statistical significant difference in participation rates by race. And I really highlight this study because in much of my work, I have found that individuals often of color are not offered trials for a variety of reasons, but one of the reasons is that we tend to think they're going to be less likely to participate. And I'll show you some of that research a little bit later on. This is a significant problem that, as I mentioned before, we've been addressing. And I find that pathway incredibly useful because when I was brought to the Cancer Center at the Abramson Cancer Center about 10 years ago in 2013, I was brought there specifically to address the lack of engagement of diverse populations in clinical research. And just to give you a little bit of background about the Abramson Cancer Center, we sit right in the middle of 3 states. And so our catchment area is a little bit difficult to figure out the statistics because we have to request the cancer registries for all 3 states and then conduct statistical analyses. But having done that, you can see our population is about 7 million people, and 20% are medically underserved, and 15% of the population lives in poverty. On the right, you can see the top highest incidence and highest mortality cancers, and I've bolded for you where we see a greater than 10% difference in incidence between Black and white, and 10% difference in mortality between Black and white, so you can get a sense of the disparities as well at the Abramson Cancer Center. And so in order to begin to understand the problem, I mapped out that pathway that you saw in one of my first slides to better identify where the leaks in this pipeline and this pathways are occurring. And so we began to look at these stages from developing cancer and being in the community to accessing a clinical trial. And we categorized half of these as access to care barriers and then the other half as access to trials. And I found that distinguishing categories very useful as I began to think about potential ways to overcome these barriers. And so here was the data back in 2014, a year after I got there. And you can see that in our catchment area, 19% of the population is Black. And when you look at specifically what proportion of the population has cancer and is Black, about 16.5%. And where I started to see there was a big drop off was right there in the proportion of patients that were accessing care at the Abramson Cancer Center. And then less so, and that was the community to clinic gap, and less so the patients once they got to the center and then enrolled in trials, as you can see, that mirrored the proportion of patients, but still was underrepresenting the community proportion of patients that are Black and have cancer. And so I began to think about how we were going to address these access to care barriers. And lucky for me, I was part of the last cohort that was invited to join this organization called the ENACT, or Education Network for the Advancement of Cancer Clinical Trials. Some of you that have been out there for a while may remember them. They went defunct after that. But at the time, what they were doing was bringing teams like ours that were challenged by the underrepresentation of diverse patients on trials. And they taught us QI methods to better understand the problem and develop rapid cycle projects and interventions to intervene. And so we brought the team together, a multidisciplinary team that you see here. And the other thing we did was we wanted to conduct focus groups to better understand the experience of minority patients who were seeking care at the Abramson Cancer Center. And what we learned from the focus groups was, that the number one reason they weren't in a trial was that they were never offered a trial. And there was also low awareness and knowledge. There was the misperceptions about what trials were, often saying the words guinea pigs or believing that they would sign away their rights by signing a consent form. They did reference the historical mistreatment of people of color on trials, Tuskegee, Henrietta Lacks, for example. And then they also mentioned the out-of-pocket costs to participating in trials, as well as the lack of transportation. And some patients mentioned the lack of a caregiver. I still am haunted by a patient who told me that he would rather die of his brain meds than burden his family with additional rides to a study. And so, having known all that and understanding that patients had low awareness and were not being offered the trials upon arrival to the Abramson Cancer Center, I decided that one of the things that we had to do was to go out to the communities and raise awareness and increase knowledge so that perhaps patients could come in with a baseline awareness and knowledge and be able to be empowered to ask about trials. And that meant leaving my beautiful campus that you just saw there and going to West Philadelphia, which is where 2 of our 3 of the Abramson Cancer Center hospitals are located. We have the main hospital, University of Pennsylvania, and Penn Presbyterian located in West Philadelphia. And West Philly is a community of 5 zip codes that's predominantly Black, as you can see from the figures down here. 72% of the population identifies as Black. It's lower income, as you can see here as well. And what I heard was, we don't want cancer clinical trials. What we really want is our brothers and sisters to stop dying from cancer. And that was one of my first lessons in cultural humility, where I actually had to put my agenda about clinical trials away and really listen to my community and what they needed and what they wanted to prioritize, which was not cancer clinical trials. And what I was hearing from them were story after story about beloved members of their community, their churches, their neighborhoods who were unfortunately prematurely taken away by cancer. And that was, of course, something I knew about from the statistics that you see here, which is that the burden of cancer is unequally distributed among people of color, in particular Black males. As you can see on the left, the incidence rate is highest in Black males, and on the right, the death rates are highest in Black males. And so I began to listen and work with them and co-create programs that actually begin to address what they were wanting us to address as our cancer center, which were really programs that helped to diagnose cancer earlier when it was more treatable and patients could survive. And so with their help, we began to work on addressing those needs. And one of the programs we developed together was a colorectal cancer screening navigation program, which still exists to this day. We were able to not only show that patients who previously were not able to keep appointments in West Philadelphia, some of them did not keep appointments up to 12 times. That was my outlier in the data. And then convert them, and 80% completed the appointments with this navigation program that it provided scheduling support, raised knowledge and awareness about why it was important to get cancer screening even though you were feeling well, provided rides, and even met them at the door because many of them had such significant fear, they were paralyzed by that fear. And so that program was a great success, and about 43% of the patients that completed their colonoscopies from these 5 zip codes had at least one adenoma. And so we began to recognize this was actually a high-risk population that was benefiting greatly from this program. And so we expanded the program actually twice since that time, and it still exists today. And that just emboldened us that we could create something really beneficial for our communities, and that could identify cancer at earlier stages. And we created a second program, the Breast and Cervical Cancer Early Detection Program, which is available from the CDC, as you all know, but we weren't a site that was providing that program. And so I applied for the contract from our Department of Health in Pennsylvania to be a site. And that program allows us to provide free breast and cervical cancer screening for and underinsured women. And we established it in 2014. Also a program that has been sustained, and as you can see here, has provided thousands of free mammograms. I think we're up to like the 100th case of cancer that we've diagnosed through this program. And so it wasn't until I had done that I felt that we began to really address the community's needs. And furthermore, as an added benefit, that we were building trust. And so it was because of that trust that we were then able to then readdress the cancer clinical trial issues. And so one of the things we did together was also apply for, at the time, the NCI had a program called the National Outreach Network that allowed cancer centers to engage with their communities and translate the research that centers are doing to their communities and engage them with evidence-based strategies for cancer and cancer prevention and treatment. And so I proposed to create a network of Black churches that serve the Black communities in Philadelphia, and that together we would address the clinical trial and cancer needs of our community. And it was funded, and you can see some of the pictures here from some of our faith-based leaders. And together we developed these programs to help increase education about cancer and cancer clinical trials in the community. And the other thing we did was develop a community advisory board, because one of the things that we then, with so much of our community as partners and developed trust, that we were beginning to struggle with was the different needs that we were hearing from different community members and organizations. And so we wanted the help of a community advisory board to help address and prioritize where we would focus our work and limited resources on. And so that continues to this day. One of the things the community advisory board helped us understand was how they could not relate to our marketing materials, because they didn't tell the story of Black individuals with cancer. And so we began to work with them to tell the stories of individuals that had been treated with cancer and participated in clinical trials with our marketing team. And we also, because they opened our eyes to this, began to notice that pharma also was mostly telling the stories of their pharmaceutical agents through a homogeneous population, predominantly white population. And so we also lobbied our pharma partners to take a look at this. And you know, this is on the right, one of the recent pharmaceutical industries with a popular immunotherapy that many of us use with our patients. And I was happy to see that without coaching from us, they introduced the campaign using Black individuals as in their marketing materials. One of the other things that kept patients from participating in trials, as you saw from the quote of my patient who was talking about the burden of caregiver and rides, was that they didn't have transportation. And so we found this individual, Imran Krank, who had just graduated from Penn and won this Penn Senior Community Engagement Prize from the president, because he had developed a company called Ride Health that serves as an intermediary with hospitals and patients to provide rides for patients so that they could get their chemotherapies. And so we began to work with them to provide rides to patients who were on clinical trials. And we did a small pilot with him. And after several hundred trips that we analyzed, we found that not only were patients now keeping their appointments, and we had lower no-show rates, but we were also saving time on staff, about 30% of a staff member's time that was previously spent on coordinating rides with their insurance companies. And so this program was adopted by Penn, and not only that, but Imran has had wonderful success engaging other health systems, and so his company has gone national now, and now we use it as a standard of care for all of our patients with cancer and additional diseases that we're treating at University of Pennsylvania. And then the other thing that came up was that there were, even though some individuals were Black, it's not a monolithic community. We began to understand that some of the Black individuals were actually new immigrants from countries in Africa, and they spoke additional languages besides English. And so one of the things we did was used at the time the IRB short form in many of the languages, French Creole, that they were reporting that they had needs for. And then the other thing we did was we used to have a translating service by phone, but we all began to contract with this company called Marty, My Accessible Real-Time Trusted Interpreter, to be able to provide translation for informed consent forms for patients who spoke non-English languages. And then additional needs arose, including travel needs, but also lodging needs and the inability to afford co-pays, which they were now paying because they were coming more frequently for the study visits. And so we provided social work support and education to be able to provide these additional programs to our patients that address their lodging and co-pay relief needs. So to summarize, our community efforts really focused on education in partnership with faith-based leaders and other community organizations that had already developed trust. We developed programs to increase access to cancer screening and advisory board, culturally tailored marketing strategies, and then these strategies to mitigate transportation and lodging barriers. And after reaching about 10,000 individuals over 5 years, we then reassessed our data to determine our impact. Before I tell you that results, I will also share that in addition, one of the other things we wanted to do was to make sure that once these patients got to the door, that these protocols were available to patients and that they could be enrolled in the protocols. And so we also did education for investigators about the diseases that were disproportionate, the cancer diseases that were disproportionate in Black individuals, so that they knew what protocols we needed to open and create for our community. We work with the research coordinators as well as nurse navigators to also increase their level of education about the lack of enrollment of underrepresented individuals. And then we also worked with the clinical protocol and data management group, which allowed us to actually take things in an interesting way, which was to require that every protocol that was being submitted and resubmitted for approval actually have a satisfactory minority accrual plan. And so our CPDM, as you can imagine, began to experience a little bit of pushback about that. For example, some of the things we were hearing were like, I'm an oncologist and I don't know anything about community outreach and engagement. And so we began to work with them individually to create these tailored minority accrual plans as the COE group, Community Outreach and Engagement Group. And so that's led to us having this in existence for now. I think it's been over 5, 6, 7 years now. And so that's another strategy. And lastly, I'll tell you that we also had a patient navigator to help individuals who were diagnosed with cancer and who were Black, who were receiving education through her for cancer clinical trials. So that was going on as well. And so what we did was in 2018, we remeasured our statistics that I showed you earlier to determine the impact of our interventions, both those access to care interventions as well as those enrollment initiatives that you just heard about in the last slide. And what we found was that we had closed that initial gap that between patients being diagnosed in the community and then accessing our clinics for cancer treatment, which led to a almost twofold increase in the enrollment of patients on adult treatment trials and about a fourfold enrollment in non-therapeutic interventional trials, as well as an increase in non-interventional trials. So we had closed the gap and almost doubled the participation of Black patients on trials with those interventions. But I can tell you that even having done all of that, we knew that there were patients still not being offered trials, and I started to read more about unconscious bias and learn more about it so that I could make some significant impact there. And this is probably the best study that I have found to really bring home to me how unconscious bias manifests in the clinic. This was a study done across 5 institutions that you see listed here, where they interviewed 4 groups of stakeholders at these institutions: cancer center leaders, principal investigators, referring clinicians, and research staff. And what they learned after those interviews was that there were several themes that emerged about recruiting minority patients on cancer clinical trials. The first was that this group was perceived as more challenging. And by more challenging, they meant they had lower knowledge, for example, of clinical trials. They had language barriers. They also perceived these individuals as not ideal study candidates. And when you dive into to try to understand what that means, there's a lot of references to the projection that they will not be adherent to protocols and drop out. And then, unfortunately, many racial and ethnic stereotypes were repeated during these interviews. And I'll share some of these quotes. And also, the concerns about the mistreatment of Black patients historically also led individuals to think that Black individuals or diverse individuals had higher levels of mistrust and would not be interested in trials. And when you combine all of these perceptions that these stakeholders had and the clinic level barriers to access that we've been reviewing, that led to many providers withholding clinical trial opportunities from potential minority patients. So let me show you some quotes from these 5 themes. So the first theme, perceived to be more challenging. One person said, you know, it's just too darn hard to try to talk to them into a clinical trial. So let's just do standard of care. With regards to language barriers, language clearly was a barrier to the point where if it was a busy clinic, I wasn't going to take time to get a translator and go spend 30 minutes. With regards to them not being ideal study candidates, this person said, well, he lives by himself. How are we going to make sure he does all this? I don't think it's worth asking him to take all this on. It will be too much for him, and that judgment can be made when, in fact, this person could be perfectly capable of doing it and would do a fine job, but never has the opportunity because this particular study may not have been presented to them. Altruism was really interesting, perceived to be differential based on your racial or ethnic group. This person said, I see that degree of altruism more in Caucasian women than I do in African-American women. And this goes against the study that I showed you earlier that Joe Unger conducted that showed no statistical significant difference in accepting a trial when it is offered. About 55% of the people accept. And then the legacy of mistreatment, this person said, I will say sometimes certain ethnic groups are more concerned about having their blood drawn. Where's that blood stored? Who's going to have this? Are they in my DNA? You know, based on things that have happened in America. And so unconscious bias is definitely real, as you can see from this research study and from the data that we have that shows that a lot of patients are just simply not offered a trial. And so that led to some interesting work that I've been doing more recently with ASCO and ACCC. In 2020, shortly after George Floyd, Lori Pierce for ASCO and Randall Oyer for ACCC joined forces around this issue of the lack of diversity in cancer clinical trials, and so brought the 2 organizations together to create initiatives to really address this. And they put out a request for applications, which I responded to, and was lucky enough and fortunate enough to be invited with this wonderful group of people who have, you know, a lot of passion about this problem. And so was fortunate enough in that role to co-chair with my fellow colleagues several work groups focused on addressing unconscious bias. And so the first thing we were able to work on, Dr. Pierce and Oyer created a joint research statement from both organizations. And so that's available to all who are interested. And then we spent the majority of our time working on a framework and intervention to reduce unconscious bias. And my co-chair, Nadine Barrett from Duke, was selected also as the other co-chair because she had been working on an intervention called Just Ask at Duke that essentially tries to increase our systematically offering trials to patients with cancer. And so we were able through this group to test that as a more a widespread intervention for a wider group of individuals and develop case studies with our patient partners, and then test the impact of Just Ask, which I will share with you shortly. And then the second intervention we created was also a site self-assessment around equity, diversity, and inclusion that takes the best practices and essentially helps sites determine whether they are following those best practices to increase diversity on trials. And then based on the results, they have access to evidence-based resources to help them where they don't have those best practices establish even higher qualities of offering patients trials. So the QR codes are here, and I think I'll show them again in the next few slides in case you'd like the actual publications that I'm about to speak about. So first, Just Ask. As I mentioned, Nadine Barrett it was the person who designed this wonderful program. And essentially, it talks about how assumptions that we all make in our clinics as we're seeing patients lead to bias. And so instead of assuming, the simple premise is just ask your patients, and the modules can be completed in about 60 to 90 minutes and are open and free of charge to anyone who's interested at the website that you can see here. And essentially, it teaches us what to ask and how to ask, and to elicit what our patients' perceptions are as a way to engage them, what they think about trials, how they feel about trials, what they need to enroll in trials, and so forth, as you can see here, with always remembering to respect patients' autonomy and ability to decide for themselves what's best for them. And after creating this intervention, we also looked at the impact. And so there's two slides here. One is to look at the knowledge of key concepts about unconscious bias and the difference between equity and equality and the causes of health disparities. And what you see here is in green is the pre-scores of this knowledge questionnaire. In blue is their post just after having completed the Just Ask training. And then in yellow, it's the same post after 6 weeks. And what we wanted to know was whether this knowledge was sustained. And as you can see here, knowledge did decrease a little bit, as you can see from the bar on top, but never decreased to the point of the pre. And so some of that knowledge was retained. Here is knowledge about the strategies that you can use to ask your patients about trials. And as you can see here, these items that had to do with strategies to increase diversity and build rapport and engage underrepresented groups and so on and so forth, that we found the same thing, that knowledge increased with the intervention and was sustained 6 weeks as well. And so I'm coming up on my last two slides here just to share with you where we're going next here at the Abramson Cancer Center experience. And as you heard from patients, these out-of-pocket costs are significant and add to the barriers that patients have and face when thinking about a trial. And so we are trying to address that with the help of a partner, the Lazarus Cancer Foundation, which has a program called Improving patient access to cancer clinical trials, or known as IMPACT. And we've developed a protocol to better assess what are the barriers to enrolling in this financial reimbursement program, which provides reimbursement for travel-related costs, so lodging and transportation. And so this program, this protocol is also a multi-site protocol. We're going to study the barriers at MD Anderson and UT Southwestern. And so hopefully we'll have more information in the future about how to engage these how to engage patients in this program, which is a gem of a program. Unfortunately, 40% of the patients that are eligible never enroll in the program. And even if they enroll, another 40% don't submit receipts. So that's the problem we're trying to better understand and improve upon. And then the other thing is I recently received funding to start an Abramson Cancer Center Cancer Clinical Trials Ambassador Program, which is essentially lay individuals who have a connection to cancer, they've had cancer, or they have been a caregiver for individuals with cancer. And we're trying to better understand if these individuals can provide peer-to-peer education to individuals who are newly diagnosed and may be eligible for a clinical trial. So that's where we're going to next. So I'll end with those two slides. And I'm going to stop sharing and pass it on to my colleague, Will, who can talk about the policy related issues that we've gotten a chance to work together. And so I'll pass it on to Will so you can speak more about that, Will. Thank you so much.
Thanks so much, Carmen, for that great, tour de force of efforts to address this really important problem. And really excited to be with you all here today from rainy New York to talk about this really important topic. So as Shannon mentioned at the outset, I'm a health economist and I'm a Medicaid policy researcher. I think a lot about how Medicaid is a very powerful program that has lots of very positive effects, but also as a function of its federalist structure is also a major source of structural inequity in the United States. And that is particularly true in this context. And so I'm going to share a little bit of background and then some work we've done to understand the extent to which Medicaid plays an important policy role in limiting access or extending access to participation in clinical trials, particularly for low income and minority Americans. So as Carmen, I think, mentioned at the outset, we know that the barriers to trial participation are many and occur at all levels of our healthcare system. And this is a figure from some work by Unger and colleagues dating back now almost 10 years, where they surveyed patients to understand from their perspective the many barriers to trial participation. And it's worth noting that many of those barriers were seen as involving treatment-related issues. Those are shown in the blue bars, but almost a quarter of patients, 22%, pointed to how to pay as a key barrier. And I think that this barrier is incident sort of at different levels of the pathway that Carmen mentioned. Many protocols might exclude people who don't have insurance or whose insurance does not cover their trial participation. And then if offered a trial, ability to pay or to have trial-related costs covered may also serve as a barrier. So this is an important source of structural inequity and access to trials, as well as something that affects the personal decision to participate in a trial. And I think it's worth being clear about the sort of sources and types of trial-related costs. And so we, of course, have the research costs, the cost of the study drug, lab tests or imaging that are done solely for research purposes. As we all know, those costs are generally borne by the study sponsor, who may be an entity in the pharmaceutical industry or government. We then have so-called routine care costs. These are doctor visits, hospital stays, other things that are received in the general course of care as someone participates in a cancer clinical trial. Those are generally billed to the insurer. There may often be a patient copay. And then there are the indirect costs, travel and lodging, time away from work, lost wages. And those are often costs that are borne by patients. Now, there's been an evolving policy context here that I think specifically affects the incidence of routine care costs. And that's what I'm going to focus on in the next few minutes before our discussion. So beginning in 2000, there was a Medicare national coverage determination that basically mandated the coverage of the routine costs of participating in the clinical trial for Medicare beneficiaries. And so beginning in 2000, those costs were borne by this federal payer for folks who are enrolled in the Medicare program. In 2010, the Affordable Care Act extended that mandate to individuals who were commercially insured, and that provision of the ACA was effective beginning in 2014. Now, there's been some work on the effect of these mandates on enrollment in clinical trials. So this work by Gross and colleagues examined whether the mandate in Medicare increased enrollment of older Americans in clinical trials. And it's worth noting in this context, they found really no effects. So the sort of key effect from this analysis is shown on this table here. They found a 1.1 greater odds of older Americans being enrolled in clinical trials after the Medicare coverage mandate. And in fact, they found that this coverage mandate was associated with decreases in enrollment of Black Medicare beneficiaries. Now, predating these mandates, there have been a number of states on their own that have mandated coverage of the routine costs of clinical trials by private payers. This is some other work by Carrie Gross and colleagues. And in this context, they had sort of mixed findings where at the top here, you can see basically two lines, individuals in states that have these coverage mandates that private insurers have to cover the costs of being in a clinical trial, and that's shown in the dotted line, versus individuals in other states, that's in the solid line. These data are shown for folks enrolling in phase 3 trials on top versus phase 2 trials on bottom. And you can see here that there is evidence that states mandating that private payers cover the routine costs of trial participation, that had a significant effect on a phase 2 trial enrollment in the bottom figure. So that's where you see the dotted line separating from the solid line, but not in phase 3 trial enrollment. Now, the landscape has continued to evolve, and most recently, in 2020, the end-of-year omnibus spending bill passed by Congress included the so-called Clinical Treatment Act. And this act, this provision in the omnibus bill, for the first time, mandated the coverage of the routine costs of trial participation in Medicaid nationally, and that was effective beginning this past year, beginning January 1, 2022. Now, it's important to note that, although this is the first time there was a federal mandate in Medicaid, so Medicaid before this period was not required to cover the costs of the routine costs of trial participation, states did have discretion, and there were 16 states shown here in blue that did cover the routine costs of trial participation. And this is all occurring within a landscape in Medicaid that has changed a lot over time with expansion of Medicaid eligibility under the ACA. And so from a policy perspective, thinking about how Medicaid might affect equitable enrollment in clinical trials, we have two things happening here. One is that we've had huge increases in Medicaid enrollment in the now 41 states and the District of Columbia that have adopted Medicaid expansion under the ACA. So you have significantly improved access to healthcare coverage and to care. And one might hypothesize that would improve equitable enrollment in clinical trials, barriers to coverage, barriers to care being, a key structural driver of the inequity that Carmen introduced us to at the beginning. But then also we might expect that any effect of expansion really should be seen in the states that historically have mandated the coverage of trial costs, recognizing that it's not until 2022 that we now have this federal mandate in place. And so I want to quickly, preview some sort of hot off the press results we have under review at a journal where we're trying to understand the sort of interaction between these two policy effects. And so in this work, we're first attempting to measure the effect of the ACA's Medicaid expansion on Black and Hispanic patient participation in cancer clinical trials. And then we're going to measure heterogeneity in that effect based on whether states have historically mandated coverage of the routine costs of trial participation in Medicaid. And I should be clear, we're focusing on the Black and Hispanic patient populations because in the data we have access to, those are the populations where we're sufficiently powered to detect meaningful effects. And so to conduct this analysis, we're going to rely on what we call in economics, a difference in differences analysis. And I'll have another few slides explaining that in a second. But in essence, we're comparing what happens pre and expansion of Medicaid eligibility under the ACA relative to post in states that expanded relative to those that didn't. And we're going to examine heterogeneity in that effect based on whether states have in place these mandates that the Medicaid programs in those states have to cover the routine costs of trial participation. We're going to focus on adult participants in therapeutic cancer clinical trials over the period 2012, so 2 years before most states expanded under the ACA, and then through 2019, about 5 years post. We're leveraging data from the metadata Rave platform. This is a back-end IT vendor that supports a large portion of clinical trials in the US and collection of trial accrual data. And we're going to focus on an outcome of whether a participant's race is or ethnicity is Black or Hispanic relative to non-Black or non-Hispanic. And so for those of you who might be unfamiliar with the difference in differences research design, this is the basic concept where we have a treatment and control group. In this case, the treatment group is states that expanded under the ACA, control states did not. We have some sort of pre-expansion difference before expansion was implemented, and we can measure that in the data. We have some post-intervention difference, and then in effect, we're taking the difference in difference. And so we're estimating the change over time for treatment relative to control groups, netting out sort of any secular trend that we think is affecting both groups at the same time, where we're sort of isolating this policy effect. And so we think we found pretty striking results, whereas when we sort of separately look at states with coverage of routine costs, and that's shown on the right here, versus states without coverage of routine costs, that's shown on the left, we see a pretty meaningful rise in Black or Hispanic participation in trials in expansion states relative to non-expansion states. So expansion states here are shown in blue, non-expansion states are shown in red. And just to put some numbers on that, so overall, we actually don't see much of an effect. When we look across all states, expansion and non-expansion at the same time, we find that in expansion states, Black or Hispanic participation in trials went up from 13.4% to 13.8%. In non-expansion states, it went down from 17% to 15.2%. That 2 percentage point difference in difference is not statistically significant. But if we look just at states with coverage mandates, with mandates that Medicaid cover the routine costs of trial participation, and those mandates were in effect prior to 2014, when most states implemented Medicaid expansion under the ACA, we find actually a 7 percentage point increase in Black or Hispanic patient participation in trials in expansion states, so 12.6% to 19.7%, and then a 3.4 percentage point decrease in Black or Hispanic participation in non-expansion states. That leads to a difference in difference estimate, so an effect estimate from expansion in these states of 4.5 percentage points, and that is statistically significant. So we find pretty meaningful effects that Medicaid expansion can improve equity in clinical trials when it is paired with these coverage mandates that states have to cover the routine costs of trial participation. So in summary, we found Medicaid expansion was associated with a significant increase in the proportion of Black or Hispanic oncology trial participants, specifically in states that mandated Medicaid coverage of the routine costs of trial participation, but notably not overall across all states, and so including those that did not have these coverage mandates. We think these are, suggestive findings that Medicaid policies have the potential to advance equitable enrollment in clinical trials. And, I think it's worth highlighting that there are a variety of other ways that I think Medicaid, as a function of the breadth of coverage offered in the program and state level flexibilities, has real potential to be an important policy lever for improving equity in clinical trials. So Medicaid is fairly unique among payers in including a non-emergency medical transportation benefit, which we see as a key opportunity for addressing transportation-related barriers to care. Every state structures their NEMT benefit differently. Many states impose meaningful restrictions on who can use the benefit and how often it can be used. But we think that state efforts to expand access to NEMT specifically for cancer patients and for those who are enrolling in cancer clinical trials really could be a meaningful opportunity to further use Medicaid to improve equity in trials. Medicaid flexibility would also allow for the program to help fund patient navigator programs. I think similar to many of those that Carmen has highlighted, where you could rely on trained individuals or peers in some cases who are trusted advisors who can help folks understand the trial opportunities that are available and provide guidance on the process. I should also mention that flexibilities in the Medicaid program would also potentially allow it to address other traditionally patient-facing costs that have served as barriers to participation. So I know there are states that have experimented, for example, with Medicaid covering the costs of lodging when folks have to seek treatment in a clinical trial in an area that's not near their residence or even out of state. I and my colleagues have also had a couple of focus groups with state Medicaid directors as they've sought to implement this federal mandate. And I think it's worth highlighting that a number of important challenges have come up in those conversations. So one is that, this policy change that went into effect on January 1st, 2022 is not particularly well known. It's actually not well known by many policymakers, and it's not well known by providers. And so we certainly need to, I think, increase awareness of this policy change to ensure that to the extent, Medicaid enrollment was perhaps an explicit exclusion criterion in certain clinical trial protocols in the past, that we know that Medicaid should not be a barrier going forward. There's also some ambiguity in the federal guidance on exactly what state coverage needs to look like in this space and the extent of the benefit, and what types of wraparound costs of trial participation should be covered. And I think that ambiguity has led to some slower adoption in some states and has made it difficult for some states to develop budgetary estimates of the cost of this coverage change. And in some states, when coverage changes involve meaningful fiscal implications, that requires approval from state legislatures. And so all of that, I think, has slowed down implementation in a number of states. And then lastly, data, our state's ability to reimburse for trial-related costs really requires that when providers are submitting claims for these services in Medicaid, that they're using the right procedure codes and diagnosis codes, and that traditionally has been difficult to do in a way that allows the states to track receipt of these services effectively. So I think that was a very quick whirlwind tour on some recent evidence that we have that suggests Medicaid as a source of coverage and can meaningfully improve access to care, and when paired with mandated coverage of the routine costs of trial participation, seems that it can also improve equitable enrollment in clinical trials. And so I want to conclude just by acknowledging a few collaborators in this work. I've been co-leading this work with Samuel Takvorian, who's an oncologist and health services researcher at Penn, also Paula Chatterjee at Penn, and then a long list of folks at Metadata led by Elizabeth Lamont. So I'm going to end there, and I think we'll transition into our Q&A segment, but looking forward to a great conversation.
Thank you so much to both our speakers. I thought both of those presentations were excellent. I learned so much, so thank you so much. I am going to go ahead and open up the Q&A, and I believe we already have some questions and comments in the chat. So I think we'll go ahead and start with those.
Yeah, I can read them. So one question that came in for Will, any suggestions on how to prove that a state has implemented the federal Medicaid coverage mandate?
It's a great question. I think there are a few potential avenues to go down. I would hope that most states that have implemented would release some guidance for providers. Many states have different approaches for this, but they might include it in sort of an annual manual outlining sort of the breadth of Medicaid coverage rules. They might put out like a Dear Colleagues letter. And so, I would hope and would certainly encourage state Medicaid programs to be really proactive in messaging on this topic. One other question is, whether you're in a state that has a meaningful presence of Medicaid managed care, in which case, the Medicaid managed care plans might be the best source of information on coverage, and, reaching out to their provider liaisons might be a good first step.
Another one that came in for Will. The non-expansion states had much higher pre-intervention enrollment rates compared to expansion states. The size and direction of the initial differences seems counterintuitive. Is there an explanation for that?
Yeah, so we really are not sure. The data set we have for metadata is individual level de-identified with sort of very few demographic variables. And so we're limited with those data in our ability to unpack a lot of potential mechanisms here. And so we are actively doing follow-up work using data from other sources, including Flatiron Health, which maintains a large set of data from primarily community health centers with a wider set of information on patient characteristics to unpack some of those mechanisms. But yeah, it's a great question.
Yeah, if anyone else has any other, I know Dr. Guerra answered the question in the chat. Thank you very much. If anyone has any other questions or thoughts, feel free to unmute or drop them in the chat.
I think I saw the question from Tasha, and I'll just point to some other recent evidence. So Marcella Alshan at the Harvard Kennedy School and some colleagues have done some work where some experimental work where they found that trust is an important mediator of participation in trials, and so they have found that when there's evidence that trials for a given pharmaceutical intervention were equitable, had equitable enrollment, that increases the likelihood that providers will offer those treatments to minority patients, and increases the likelihood that minority patients will consent to receiving that treatment. And so that I think points to another way, or another important reason why this goal of equitable enrollment is so important.
Dr. Guerra, I was going to ask you a question about how to, you said, you first started out kind of going into the communities that you were trying to better understand and try to help. I was wondering, did you have a team with you? Did you have patient advocates from that community with you? Is that a helpful or something that's beneficial, is to actually engage with advocates in that community to help you to, I guess, establish some trust and communication?
Absolutely, yes, Sneha, what a great question. And I'll tell you how that evolved. When I moved to the Cancer Center, I was told that I would have staff support, and that in fact there was a staff member who was looking for an opportunity to work at the Cancer Center because her PI was leaving Penn and going to another institution. It was Shanita Hughes Halbert. For those of you who know Disparity's work, you might recognize her name, but she was moving to the Medical College of South Carolina. And so this woman was looking for work. She contacted our Cancer Center, and I was introduced to her, and I met her, and absolutely lovely Black woman who had been a patient navigator in the community under Shanita's trials for a long time. And one of the things I asked her during my interview was, what do you do when you're not at work? And she said, well, I serve as the cancer minister at Enon Tabernacle Church. And I said, what does a cancer minister do? And she said, well, it's a volunteer role where I lead individuals who are diagnosed with cancer or family members caring for individuals with cancer in prayer. And so I asked if, with time, would she feel comfortable introducing us to the pastor there? And she was delighted and navigated that relationship for me to be able to meet the pastors there. And I was amazed at how much trust she already had in the community. It would have taken me maybe much longer, as you were indicating in your question. But for her, it was like, Sister Brenda, what can I do with you? And whatever you need, Sister Brenda, we're here to partner with you. And so your question just brings up something that, is not as evident when you do this kind of work, that you really do need a navigator yourself in communities where perhaps you haven't been to before to try to educate or increase an intervention, or so she was absolutely essential. And so now that's become one of my standard interview questions. I ask individuals what they do outside of work, because it was important to recognize that people have valuable networks, and that we probably underutilize those networks in our healthcare roles and research. So thank you for the great question.
We've got another one in the chat for both speakers. This person is curious about your thoughts on who is the appropriate funder of the clinical care costs for research participants. Is it the research sponsor? Is it Medicaid, Medicare, private insurance? And then are these costs the patients should have incurred through normal care outside the trial, or are they additional costs because of the trial?
I can start, Will, or if you'd like to start, please go ahead.
Yeah, go ahead.
I was going to say that, a lot of sponsors are actually a bit shy and stay away from funding expenses on trials. And if I look at my institution, it's a fraction of sponsors that actually provide in their budgets funding for reimbursement of clinical trial related expenses. And that's because they're concerned about this appearing to be undue influence or coercion. And so, it's difficult to help them understand that they would be okay doing that, because there are no laws in place that actually make it explicitly clear that this is not coercion. In fact, it's the other way around. And so what we've had to do in Pennsylvania to start this patient reimbursement program was actually go to lobby our senators to sponsor a bill that explicitly says that reimbursing patients with cancer for their clinical trial related expenses is not undue influence. And that's how we were able to work with our partner, the Lazarus Foundation, to establish that program only after that law went into effect. The Lazarus has worked with Massachusetts, California, Texas, which is why our colleagues are at Texas, but also recently been working with Chicago. And I've been thinking about how ineffective that is, because you can't do this patchwork state by state by state. And what we really need is a federal law that provides a safe harbor for sponsors to be able to do this without that concern and fear. Will?
Yeah, no, I agree with all of that. I mean, I think just to be clear about sort of the current state of the world, these routine costs involve, basically care you would receive in absence of a trial, but also, just sort of general services that you receive as part of the trial, but that aren't related to administration of the intervention or, testing for research purposes. And so if you're staying in a hospital, bed because you're enrolled in a trial or because of a side effect of that trial, that's a cost that at this point is generally borne by the insurer, or if you're uninsured, by the individual patient. And so sort of the current policy environment is that these routine costs are borne by the insurer. There's broader out-of-pocket costs that are, generally not reimbursed, unless you take part in some of the, special initiatives that Carmen mentioned. And, my own take is that participation in clinical trials for many patients represents, access to, the latest medical technologies. And so, that is a service that should be provided by the payer. And so I think payers covering these services to me seems relevant. I think it's particularly relevant for public payers. Public payers are effectively then also investing in the public good of equitable enrollment in clinical trials. And, as Carmen highlighted, we know there are lots of broader social benefits to equitable enrollment in clinical trials. And so, yes, my own perspective, both from like an economic efficiency perspective, but also from I guess broader sort of moral imperative perspective, is that that's really an important role for public and private payers to play.
Thanks, Will. And we've got one more in the chat. What advice do you have for future oncology physicians and health providers about how to keep equity at the forefront of cancer care?
I can start again. Great question again, and thank you for that question, Rachel. I would say that one important thing that we should do when we're looking at access or quality of care is just to look at the data stratified by race and ethnicity. So for example, looking at clinic no-show rates or chemotherapy infusion rates, we often see those figures, but we never see them stratified by race or ethnicity. And that would be something important. Another stratification one can do would be looking at rural counties versus suburban/urban counties, because we know that rural residents have a harder time accessing cancer treatments. So that would be one thing. And then I think we know, as you saw in the study, that unconscious bias is really real. And it's beyond clinical trial offering. It actually, affects everything we do in healthcare. And so being mindful and understanding that that we're human, and if you're human, you have biases. Some are good and some are not so good, the biases. And so understanding that we do have those biases, and then perhaps seeking training such as the Just Ask or other unconscious bias training can help us better understand how to reduce and mitigate those biases. But Will, do you have other suggestions?
No, I completely agree. I think from a data perspective, we can't seek to address what we don't understand. And, I think as many of you on this call know, the sort of data environment around this problem of equitable enrollment in particular is quite challenging. Many cancer centers don't have great data on the race and ethnicity of their patients. That's also true for state Medicaid programs. Race and ethnicity is actually not a mandated data element that individuals have to provide to Medicaid programs when they enroll. It's optional. When it comes to trials themselves, historically, both the NIH and FDA have not had, super stringent standards or enforcement mechanisms to promote transparency around equity in trial enrollment. And, the work I showed you, we ended up partnering with a proprietary data vendor, in part because, whether it be through NCI or other entities, there really is not a really accessible source of data on the racial and ethnic composition of a representative set of clinical trials in the US. So I think both at like the individual provider organization level, but also from a broader policy perspective, I think anything we can do to improve data around the race and ethnicity of participants in trials or in care more broadly is the first step to understanding where there are opportunities to improve equity. So wholeheartedly, I think, endorse that point. Another thing I guess I would say that I think is a big lesson from a lot of Carmen's work is really the important, if we seek to keep equity at the forefront of engaging with communities and creating trusted relationships with communities and have communities drive what we focus on. I guess I don't want to maybe skip out of turn here to the next question, but I think in my mind that's a key thing that cancer control coalitions can help to facilitate is really thinking about opportunities to partner with key community organizations that are trusted entities in areas that have a large portion of individuals who have historically been underserved by our healthcare systems, and investing in those relationships to understand where there might be mistrust, and to understand community priorities to sort of inform the work at the state level going forward.
Anything to add, Carmen, for the State Cancer Coalition question?
Briefly, because I know we're running a little short on time, but yes, absolutely. I would say agree with what Will mentioned. I think understanding and helping sites just collect the data is absolutely critical. I also think that state cancer coalitions can bring many partners together that can address those barriers to accessing care, but also trials. The American Cancer Society, as I mentioned in one of my slides, is usually someone we engage in cancer coalitions, and they have many resources to be able to address those barriers that patients face. And then the last would be policy, advocating for some of the policies that you heard Will cover so nicely that actually have increased engagement and participation in cancer clinical trials. Policies like we passed in Pennsylvania to assure that reimbursement was not undue coercion, what is another important one. And I believe there's a national policy, the Diverse Trials Act, that is currently has sponsors both at the House and in the Senate, that would provide those safe harbors for pharmaceutical industries to be able to provide the reimbursement of out-of-pocket costs. And then, helping institutions learn from one another. For example, the institutional policy that we had to require minority accrual plans kind of was ahead of its time, because now the FDA is requiring, strongly suggesting, not requiring yet, that protocols have a minority accrual plan. One of the things that I'm actually doing to actually help that requirement is several colleagues and trainees and are building a minority accrual toolbox that's specific to our population, and it has important resources. So, for example, how do you get the word out about studies in the different racial and ethnic communities that we serve? What are the translation services one can use for a protocol if one is planning to recruit heavily from different populations? So we're building it, and is it something, when we were building it, we realized, I don't think this is something that is just something we can disseminate widely, because so many of the resources are unique to our communities. And so it's something that different individual communities may have to adapt or add to, but we are working on a few ideas to help those minority accrual plan.
Thanks, Carmen. And we'll close out with one more question from the chat before I make it over to Kelly. But Small question on the data. How is medically underserved defined in your data? Was that at the individual level or zip code census level?
Yes, it's actually medically underserved has a definition based on the number of providers within a certain geographic region. And that's what we were using for our definition. And is it Kate? Oh, yes, Kate asked that question. So Kate, I can find you the HRSA definition. But if you also wanted to look up the definition, you should be able to find it in Health Resources and Service Administration.gov.
All right. Wow. Thank you so much, Dr. Guerra and Dr. Schpero. We just appreciate this tremendously. And I love how you said, Dr. Guerra, that coalitions can help groups and institutions learn from one another. And I know that we have many, many different institutions represented on this call today or webinar today. So thank you both for sharing your knowledge. We had people from across the country register. So thanks for sharing it far and wide. Before we wrap up today, I do want to provide just a couple updates from the Iowa Cancer Consortium. And two very quick ones. One is hopefully you have all seen, or you may be new to the consortium because we know that we had some new folks sign up for this webinar who may not have crossed paths with the consortium before. We've recently released the 2023 Iowa Cancer Plan. There will be a link dropped in the chat for you here just briefly. And the cancer plan reflects so much of what was included and covered in today's presentation. It leads with health equity at the center and running throughout. So if you're not familiar with the Iowa Cancer Plan, we encourage you to take a look at it. It's meant to be a guiding document for the entire state. It's not a strategic plan just for the coalition. It's really meant to be a document that outlines the priorities, strategies, the key actions that need to be taken to reduce the burden of cancer here in our state. It was developed collaboratively with input from many, many stakeholder groups. Please check it out and send us your input. This is meant to be a living document, and so we want to hear how it's useful to you and if you have suggestions for how it might be more useful. And then we know a lot of folks on the call today probably have an interest in patient navigation or navigation of some kind. We want to let you know about the recent launch of something called the Iowa Oncology Navigation Network, or ION, and there will be a link dropped in the chat for that as well. This is a network of people who are working in some sort of navigation field. So whether that's social work, whether navigator is actually part of their title, whether they're a community health worker, this is a place for those folks who are navigating oncology patients and caregivers somehow in the state of Iowa to connect with each other, to make it easier to find resources in other parts of the state. We know that in a state like Iowa that is so rural in places, it can be really tough to find resources for patients who have to travel. Check out the link in your chat if you're interested in knowing more about that. And then one last link that we'll drop in the chat box is our staff@canceriowa.org email address. If you have questions about anything, are looking for collaborators on any type of cancer focused work, please let us hear about it. We'd love to help you find resources and other partners as well. And I think with that, we'll end with one more thank you for our speakers. Thank you so much. And thanks to Dr. Fadke and Shannon Benson for facilitating today. We will hang on the meeting for just a bit in case anybody has any final questions. Otherwise, please enjoy the rest of your afternoon, and thank you so much.